Hello, everybody, and welcome to the SABA short-acting beta-agonist overuse in children aged 5 to 18. My name is Christiana, Medicines Optimization Pharmacist for the Bob ICB, and alongside me today, I'll be presenting with Paula Matson, who is a respiratory specialist nurse, community clinical lead for Bob ICB. It's not changed. It's not changing. Okay. Okay, so just a few housekeeping rules. Apologies, I can't see everybody. Just make sure your cameras are switched off if you've got them on, and put your microphone on mute. And any questions relating to the target being discussed, please can you kindly post that onto the chat so members of the MOT team would respond to them. This webinar is being recorded and will be posted onto the SharePoint page of the PQS SharePoint page, which you should have all access to after this session. Can I ask you to go on mute, please? So just a brief agenda of the meeting. I'll be giving a brief introduction to the PQS in general, and also talking about the SABA overuse target one. Then I'll pass on to Paula, who would go over the overuse of SABAs in pediatric patients, and then we would have questions at the end. So the PQS scheme in total is an optional scheme and is open to all practices within the Bob ICB. It's designed to improve quality, safety, and cost effectiveness of prescribing across Bob. The scheme runs from 1st of April to the 31st of March 2026. There are 5 targets in this year's scheme, plus the script switch PQS elements. Each target is worth 20 points each to make up a total point of 100. And practices can choose to do all the targets, or they could choose to do some of the targets. An email was sent already to the practice managers on the 8th of April to inform practices of the value of the scheme. If a practice chooses to do some of the targets, they will be paid in proportion of whichever targets they choose to complete. You should be familiar with the criteria and the participation of payment, which includes the script switch element as well. And those who choose to participate, we're asking, could you please kindly sign the participation agreement form and return them to the Bob MOT inbox by the 31st of May. So let me just touch briefly on the script switch PQS elements, because this is key and will be monitored throughout if you do sign up for the PQS scheme this year. So you'll be monitored based on 2 criteria, which will be the prescription logged and the offer rate. So for each practice, the prescription log must remain at 65% or above of their monthly average for at least 8 of 12 months across the year. And for the offer rate, practices are asked to will be monitored on a monthly basis, and their offer rate exceeding 8% must demonstrate a reduction of at least 1% to achieve a rate below 8% by the 31st of March. The script switch PQS requirement webinar took place last week. If you would like to listen to the recording on that, and just to make yourself aware and of the requirements for this year, I've included a link on this slide so you could have a look and get familiar with the criteria for claiming this year. But we've arranged future webinars for all our targets. So for the ONS target, there is a webinar later on this week. And for the DUAC in patients with AF, optimizing their medication, we've got a webinar planned for next week. We'll keep you informed of the falls prevention webinar, which once is agreed. So all the PQS resources, the agreement forms, the clinical system searches, the data collection spreadsheets, instructions, and the recorded webinars are all in the SharePoint page, PQS page. And if you have any problems or any issues accessing this page, please contact us at the Bob MOT inbox below. So I'll move on to the target. So target 1 is the use of to review. We're asking practices to review patients identified age 5 to 18 diagnosed with asthma who are being prescribed 3 or more SABA inhalers in the last 12 months. And mainly is to investigate the reasons as to why there is an overuse of SABAs. The reason why we've asked practices to do this review is because we know from the HENRAD reports that one of the major potential risk factors that led to deaths, children's deaths in asthma, was the fact that there was overuse of SABAs. And we also know that the latest BTS NICE sign guidelines that was published last year has recommended not to prescribe SABA alone for children or patients of any age without prescribing an ICS. And it's also recommended that patients aged 12 or over with uncontrolled asthma should have their treatment changed to a non-SABA regime, and also to consider pediatric low-dose mats for children with asthma that is not controlled on a pediatric low-dose ICS plus SABA, if they have the ability to manage a mat regime. So quite recently, in the last month, we've had MHRA alerts about the use of, reminding clinicians about the use of SABA alone and the risk of the overuse of SABA in asthmatic patients, and the increased risk of severe asthmatic attacks and increased mortality rates. So this is just highlighting the reason why we need to change our clinical practice and educate more healthcare professionals not to prescribe SABA on its own and always think about prescribing an ICS. There's also a risk on the use of montelukast in children. So I just thought I would just highlight this as well on the MHRA alert. So we're just reminding patients of the risk of the neuropsychiatric reactions in patients. So they should be monitored. And if they do report any reactions to montelukast, such as sleep disorders, hallucinations, anxiety and depression, or if there's any changes in behavior or mood, we're advising healthcare professionals to raise this and seek medical advice. So for the SABA overuse targets, we've included some inclusions and exclusions criteria. So in the inclusions criteria, we're looking at patients aged between the age of 5 to 18 who have been prescribed 3 or more short-acting beta agonist inhalers in the last 12 months only. We are excluding patients that are not on the asthma register. So if they're being prescribed it for a viral illness or for a cough, which they shouldn't be reviewed. We are also excluding patients that are on the specialist respiratory team, so for their asthma management, and if they have a follow-up plan arranged, I think we don't want them to be. You can review them, but we excluded them for this PQS requirement. And we are also excluding patients under the age of 5, but we know that some patients under the age of 5 would have had 3 or more SABA inhalers in the last 12 months. And if you do find those patients and you wish to have a cohort of patients to review in future, just send us an email so we can help with the searches to identify those patient group. So this particular target will be measured by you returning the data completion templates and also returning a practice improvement plan. So the data search and the collection templates is as shown. So we've run the EMIS web search, and that is on the instructions in the data search and collection templates. All the searches can be found on the SharePoint if you haven't got that information at hand. The search will provide a list of patients, and usually on the top column here, you will find all this information on the top can be found from the search. So can be pre-populated from the search. And what we're asking practices to do is to populate this bit here, the bottom section of the data collection, which basically lets us know what the reasons why patients are over-ordering. Is it due to lack of control, or is it due to prescription clerk errors, or is it due to it because the medication is on repeat prescription and it just keeps getting ordered? So there could be a clinical or non-clinical intervention, and we're asking practices to complete these columns here. Once completed, we would advise that you return them to the MOT inbox for review by the panel. We're asking practices to also complete an implementation and key learning plan for the practice. So if you've done your audit and you've come across patients that you would like to then change your practice, or you would like to improve the way your asthma clinics are run, we would like to know about what changes have been made and implemented within your practice. And this is where we would like information, just a brief summary of what you've learned from undertaking the audit, and also actions that you've put in place within your practices to ensure that you're safely prescribing SABAs in this age group. From previous experiences, we've had evidences that have been returned without any actions or outcomes completed. So I'm urging that if you can, please review, when you carry out your reviews, whatever the outcome is or the action is must be completed onto the evidence page, and before the evidence is submitted by the deadline, 3rd of May, 2026. So I'll pass now on to Paula Matson, my colleague, who will be able to go on to the SABA overuse in pediatrics.
Many thanks, Christiana. So yes, you can see who I am on the screen. Majority of my background has been in respiratory, working in primary care, both in the diagnosis and management of all age groups, actually, from birth cradle to grave, as we say. And I've also worked as community respiratory and home oxygen nurse. Next slide, please. Thank you. So the contents I was going to look to cover this afternoon are just going over a few facts on asthma. I was then going to obviously update on how the guidelines have changed into our recommendations and diagnosis of asthma in the age groups from age 5 to 16 years of age. Then I was going to give a brief overview, which Christiana's already done to a bit actually, but the management as per NICE BTS Sign 2024, which was released at the end of November. And then just looking into how many SABAs is too many. Thank you. Next slide. So just a few facts on asthma to cover them, to give you a bit of background. So in the UK, we've got approximately 5.4 million people living with asthma currently. This would equate to 1 in every 12 adults and 1 in every 11 children. So in any school year, it's likely that there will be 3 children living with an asthma diagnosis in every class. So in Bob, there's currently 115,968 people of 6 years of age and upwards diagnosed as living with asthma. So this gives us an overall prevalence of about 6.2%, which is actually below the national median of 7%. And the range of prevalence at practice level varies anything between 2.24% to 8.66%. So it's actually quite interesting for everybody logged in to have a look at how your practice is currently doing with your prevalence rates. Historically in the UK, 70% of prescribed inhalers have been pressurized meter dose inhaler devices. And we know that we've certainly got an ongoing national push to favour prescribing dry powder inhalers devices as it's less harmful to the environment. Plus, generally for the majority, they are easier to use, and children can also use dry powder devices as long as you check it's appropriate for the individual in front of you. Next slide, please. So making the diagnosis of asthma, you want to look to check the symptoms, and the typical symptoms that someone would present with would be wheeze, noisy breathing, might be a cough, breathlessness, chest tightness. Moving on, and you've got an increased probability of that being asthma if the symptoms are currently episodic, diurnal, which is generally worse at night or early hours of the morning, or seasonal. And certainly at the moment, we're going through heavy pollen season. Increased probability if you've got a family history of atopy, asthma, eczema, hay fever, allergic rhinitis, and we know that 80% of asthmatics will also have coexisting allergic rhinitis. And symptoms will vary over time and in intensity. So symptoms tend to be triggered by many different factors, commonly exercised, allergen exposure, pets, changes in weather, which we get where we're living in the UK all the time, non-steroidal anti-inflammatories, that includes topical, viral colds, irritant fumes, smoke, strong smells, emotion, and the list goes on. Move on, please. So if we get on to thinking about the diagnosis. So for a diagnosis, a healthcare practitioner needs to match the presentation, the history, the symptoms and physical examination by listening to the chest, the objective test to try and build a whole, and it's like constructing a jigsaw puzzle, as we always say. So seeing if everything comes together to make that whole. So possible tests, as they're now recommended by NICE BTS Signed, is from 5 years of age. First line test you perform is fractional exhaled nitric oxide monitoring. And if that result is inconclusive, you would go on to do spirometry of reversibility. And if it's not easily available or you've got a long wait, then peak expiratory flow readings or bronchodilator reversibility through peak flow readings. If you've tried and you're still uncertain of a diagnosis, NICE now recommend for the under 16s skin prick testing to house dust mite, and that would be via specialist referral to secondary care. We move on, please. So to talk about pheno, the beauty of having pheno is it's easily accessible and quick to do if you have it in-house in the surgery. And for those of you who have signed up to the spirometry and pheno locally commissioned service, you should all have a pheno machine to ease at hand, which is very easy to use and suitable from 5 years of age and upwards. Your patient would present symptomatic, and it's the ideal time to then get a marker of what their pheno is doing. And we know that's a biomarker of eosinophilic inflammation. So a positive test result from 5 years of age to 16 is 35 parts per billion. If you have a result between 25 to 35, it's suspicious, but it's inconclusive. So those children would need to go on for further testing. But do remember, a negative result under 25 does not exclude asthma. So not all asthma is eosinophilic. You need to also be careful that the child has come in the appropriate state. And there's an excellent NHS advice leaflet for children into ideal opportunity for presentation for testing. Ideally, now it would be very unusual for a very young child to be smoking, but they need to not have had any exposure to smoke particles, ideally for 4 hours. They also shouldn't have had any leafy green vegetables or beetroot or celery, because it can actually falsely raise the level of pheno, whereas smoke inhalation can actually falsely lower the level of pheno. They shouldn't have had a hot drink, nor should they have participated in an activity where they're exerting themselves. And if you're going to do pheno and spirometry all in the same day, the pheno test is obviously done first. So a positive pheno level of 35 parts per billion is your conclusive test result to match your clinical history to say it is asthma. We move on, please. We've also second line, if you haven't had a conclusive test result by doing pheno, you can do your spirometry with reversibility, and the locally commissioned service would say we can again also do this from 5 years of age upwards. To do the test on anybody under the age of 16, that you only need to do the forced volume capacity blows for all the recordings pre and post salbutamol. And we tend to do the baseline readings. Generally, for majority, we give 4 doses of salbutamol, good inhaler technique, with approximately 20 minutes, and repeat the forced blows again. A positive asthma type response, what we're looking for is a change in what we call the FEV1. So that's your forced expiratory volume in 1 second. So it's basically the reading taken from that first second of when the child has done their forced blow. And we look to see how that changes in response to exposure to salbutamol or the beta-2 agonist. So a positive change would be a change of 12% or greater. Again, if there's a negative test result, it does not necessarily exclude asthma as a diagnosis. It will depend on whether the child is presenting symptomatic at that point of testing, because it's not something we can just fit into any clinic. It takes approximately 1 hour to do a full test result for any presenting child. So it's not something we can just free up in any given day. So you have to book in advance. And again, the child would be given advice on what they should exclude or take prior to attendance. Can you move on, please? So this is a screenshot taken from the NICE guidelines on objective tests for diagnosing an asthma in children aged 5 to 16 with a history suggestive of that diagnosis. So you can see the order of tests is, as we've said already, FeNO first line if it's available. If it's not or inconclusive, then bronchodilator reversibility with spirometry. Again, if this is inconclusive or not available, peak expiratory flow variability, or finally, if we're still not sure of diagnosis, skin prick testing to house dust mite. So interpretation of test results is the FeNO 35 parts per billion or more. If yes, with a history suggestive of asthma, that's your confirmation of diagnosis. If not, you're looking for reversibility airflow obstruction of 12% or more in the 5 to 16-year-olds with your spirometry. Again, that's your conclusive test if it is. If it's delayed or not available or inconclusive, you might choose to do peak flow readings with variability or reversibility of 20% or more. An excellent website to calculate the variability if you've got a peak flow diary coming back in to be interpreted is Asthma and Lung UK have got a peak flow variability calculator online. And you can add readings for 14 days and it will tell you the variability on every given day that you've entered. If you still haven't got conclusive test results, then it's your skin prick testing once we have that readily available to us, or your wait and your repeat tests if symptoms magnify again. Can we move on, please? So, as Christiana's also alluded to, so we've got suggestive medication for anybody 5 to 12 years of age diagnosed with asthma. So what you will see here is there is nowhere where it says SABA issue alone. So anybody with a confirmed diagnosis of asthma must not have a SABA without concurrent treatment with an ICS component device. So first line would be your low dose inhaled corticosteroid twice daily with PRN SABA. And that should not be frequency of use with the PRN SABA. Then if the child is not controlled or is needing regular doses of the reliever SABA to be able to participate in sports or everyday life, the suggested move on is actually to low dose ICS LABA MART if they have the ability to use MART. But just a note is to say that there is currently nothing licensed for use for MART for the ages of 5 to 12. Whereas from 12 years of age upwards, we do have licensing agreement already in place for certainly Symbicort. So we would have to highlight to the parents or guardian that nothing is currently licensed, but we do have licensing already in place for Symbicort from the age of 6. It just isn't licensed for MART. If the child is not suitable for using MART or the parents or guardians are not happy for the child to use MART, then you would have a trial of your leukotriene receptor antagonist. So that's your montelukast in accordance alongside the low dose ICS. Always before you step up to any increased level of medication, check compliance, adherence, and importantly, also inhaler technique. If the child is not controlled on either the low-dose ICS LABA MART, if they've started it, or the trial of the leukotriene receptor antagonist, the idea is that if they are on the MART, you would step up to moderate dose MART. Alternatively, if you tried montelukast, if it was useful and it helped control symptoms, but they still weren't controlled, You could increase to ICS LABA stat dose where they take twice daily, either including the montelukast, or if the montelukast wasn't helpful, then withdrawal again. If you still have a child who is not controlled at this level of medication, it should be considered if the child should be referred into the pediatricians for advice. But always remember, check adherence, check inhaler technique, and also make sure there's not something else actually causing the symptoms in the child. Also check for any exposure to allergens or triggers that could be excluded. Next slide, please. As I keep saying, inhalation technique is key for the device that's being issued. So drug deposition is key. If the child has got a good technique, as is shown with an example of drinking water, a small dose will be clinically effective. If there's a poor technique, as you can see from the child where they've got the running tap, trying to sort of slurp in intakes of water, they're going to get a poor deposition, and you're going to see larger doses required to achieve the desired effect. So please never underestimate checking consistently inhaler technique. If they've got poor technique, they are much less likely to have good control, much more likely to overuse their SABAs. Next slide, please. So how do we assess inhaler technique? We check, we demonstrate, we recheck, we demonstrate, we recheck, and so it goes on. Every time that child comes in to be seen, we must always check inhaler technique. And you can see on the slide the different options that we have for how we check. So we've got the in-check dial device, which is readily available to most of us. Most, I would imagine, would have access to one at least within their practices. And you would set the inhalation strength to the device that the child has been issued to make sure that when they've inhaled, the red wheel is sitting in the dark green zone of the in-check dial device for that device. We can use placebo devices as well. So if the child has been issued a turbohaler, we've got trainer whistles as well. We've got obviously the elliptic device, we've got PMDI devices. So trainer whistles can be useful, particularly if the child, for example, has been issued Symbicort, because there is no taste response from Symbicort. So the child can't say that they've tasted the drug when they've inhaled it. And if the parents or guardians are a little uneasy about this, they could check using the trainer whistles to make sure that it's making the whistle noise before the child takes the actual dose from the device, which is live. We've also got the links to the techniques for all the inhaler devices on Asthma and Lung UK. But this is good for just sending through after you've already demonstrated with the child, and also assess the child's technique as well. We move on, please. So if you're planning and have booked an asthma review for a child, I would always strongly recommend that that child is seen face to face, and telephone consultations I find are not appropriate for children in particular. You cannot get a good rapport with a child on a telephone line, and actually often what's going to happen, it will be the parent or the guardian that you're speaking to. We move on to the next slide. This is a pediatric asthma control test where the child actually takes responsibility for answering the first of the questions that you can see there. So the child can coincide how they feel about any answer, with the first one being, how is your asthma today? Very bad, bad, good, and very good. Again, the second one, how much of a problem is your asthma when you run, exercise, or play sports? You can see the different answers there. Do you cough? And then do you wake during the night because of your asthma? So the child's responsible for providing the answers to those independently, and then you've got the other answers that the parent or guardian could get involved with too. And I strongly recommend using this. And I've got quite a funny instance of where I had a 10-year-old came to be reviewed with his mum in clinic, and say this is in a GP surgery. And the mum comes in first, and I said, oh, hello, lovely to see you. How are things? And she said, absolutely brilliant. He's doing really well. In fact, so well, I think he can stop his inhaled steroid. I don't think he really needs it. I said, well, that's lovely to hear. Not thinking to myself, I don't think this is possible. But anyway, we'll not say that outright. So I give the child the pediatric control test to fill in, and then we looked through the test results together. And actually, the child identified that they couldn't participate in sports at school, that he had to stop frequently during any playtime and sports times to get his reliever inhaler to take reliever doses of his salbutamol. So I was sort of saying this, that it was quite an interesting reply to see that he was struggling to run and participate in the sports. And then ensued a bit of an argument between the parent and the child, where the parent's saying, no, you're not, and the child saying, yes, I am. And so it came to the point where actually the child said, you don't know, you're not there. And the parent was saying, well, you didn't tell me. So the child then says, well, you didn't ask. So we don't always have those open lines of communication every time between the parent and child. So really doing the pediatric control test can be quite indicative and quite eye-opening for both parent, child, and for myself as a clinician too. So strongly recommend using these tests because it can actually identify poor control. And if I'd spoken, for example, to that parent down the phone line and the child hadn't been present, I actually probably wouldn't have realised that we needed to do something about the preventative level of treatment he was actually already taking. If we move on, please. So then we get to thinking about how much is too much if we're thinking about salbutamol doses. And as you've already heard, we've got the incentive that if 3 or more SABAs are being ordered in any 12-month period for a child, it should be actually highlighted and investigated. So some of you might be thinking, well, that's not that many SABAs to actually then think about. So if we move on, click the slide again, please, you'll see that if the child has 12 SABAs issued in a year, that would give access to 2,400 doses in a year, 46 in a week, and 7 in a day. And we know that 3 or more doses in a week is an indicative of poor control, where you need to actually look at their preventative treatment level. If we move on and we cut it right back down to 6 SABAs in a year, you can see this would equate to more than 3 doses in any given day. And if we move on, and we go right back down to just 2, you can see that actually having 2 SABAs in 1 year, this gives access to 400 doses, 8 in a week and 1 every day. Now, what we do know is that actually sometimes children do need more issues of SABA initially because you've got separated parents. So I would allow issues of preventative medication and reliever inhalers for each household. But then beyond that, and maybe you need to do that as an acute issue, moving onwards, you need to be careful about the number of issues. I'm very happy to give as many preventers as they wish, but I'm very resistant to actually prescribing too many SABAs. Too many SABAs, and you know that either the child is leaving them or losing them, or somebody else is using them, or they've got poor control of their actual condition. We move on, please. So if the child has been identified as overusing salbutamol and they've been identified as having 3 SABAs in a 12-month period of time, you need to actually encourage the child to be brought in urgently for review with their parent or guardian, as this is an indication that they have an inadequate level of preventative treatment currently at that point, and therefore they are at risk of exacerbation. You will always have incidences where you've got non-responders to asthma review invitations. And if this is the case and there hasn't been a response and the child hasn't been brought in for urgent review to either a text invite, written or telephone, this should be viewed as being a red flag and a trigger for a discussion within the practice regarding safeguarding issues. There have been cases across the country where children have died due to neglect because of non-attendance for chronic disease management review. So we can never underestimate the importance of children who are not brought in to be reviewed. Next slide, please. So I think most people are probably aware of the asthma and lung pediatric control action plan, and how to complete it. But often if you are moving a child up to MART, it's trying to find a plan which you think is appropriate that they would be able to understand. So this is the MART action plan, which I've actually taken a screenshot from the Primary Care Respiratory Society. And what you can see is it's a little bit more child friendly. and it's actually got some education on asthma. So a lot of the time, the problem with why people overuse their salbutamol and underuse their preventative inhaled corticosteroid device is they don't have the understanding or education to explain what each device is responsible for. The problem with salbutamol is that they will get a response within their airways that they feel and they recognize. So what this misleads them to thinking is it's causing treatment. It's actually treating their condition. Whereas in actual fact, what I tend to do for children and sometimes for adults as well, most of them will have an understanding of what eczema looks like on the skin. So for example, if you've got eczema on your skin and all you do is put an emollient on, you'll actually moisturize the top layer of the dry, flaky skin, but you don't actually treat the inflamed skin underlying why you've got the dry, flaky, itchy skin. So by treating the actual skin with a steroid emollient, what you're then going to do is treat the inflammation underlying the whole problem that they have. So that's the way I kind of explain it to parents and children as to what salbutamol is like. It's like an emollient. It's like a temporary sticking plaster, but it won't actually treat the cause of why they're getting the symptoms. So yes, you get the temporary relief, but it doesn't treat why you're getting the symptom in the first place. So Mart, what you're doing is the child will feel the response to the formoterol, which works, they say, as quickly as with salbutamol. So they get the feedback saying it helps them, but they're also getting the treatment with the inhaled steroid. So on this Primary Care Respiratory Society action plan, what you can see is an explanation around asthma. So it's giving them some education about what it actually is. You've got a space to put in their name, their surname, the Mart inhaler type, and you can upload a photograph onto the plan as well. And then it says a Mart maintenance and reliever therapy plan is a simple way to manage asthma with one inhaler. So one inhaler for everything, daily treatment and quick relief of symptoms. Convenient, easy to remember and manage. So you've just got one inhaler to learn how to use correctly. If we move on, please. Then you'll see, importantly, you've got different sort of common triggers that are used that, again, you want the child to then start to notice and identify what it is that makes them feel their symptoms. So they can tick whatever else they feel actually affects them, whether it's exercise, pets, smoke, where maybe they might be naming and shaming a parent or a guardian who's maybe smoking nearby, and etc. And other things that they might identify as saying that make them feel symptomatic, you can put in the empty space at the end. And I will generally say anything that the child conveys to me. So I want that child to know that I'm listening to them and it's their asthma to own, and I'm going to pay attention to them. So please make sure when you are having a review with a child, be it a 5-year-old, 12-year-old, 16-year-old teenager, whatever, it's the child that you want to build the rapport with as much as the parent or guardian. So do consult with the child. I read through the plan with the child, so if they're not with their parent or guardian, they will hopefully have remembered some of the advice that we've read through when we've issued the plan. So you can see the green smiley face, my asthma is good. And it's talking through, I don't have a cough or wheeze, I can exercise as usual, and I'm sleeping well. So therefore, you've got the information on the inhaler that they use, when to take it, how to take it. And it also says I use my inhaler as a reliever if I get asthma symptoms. I take 1 puff as needed. Then you've got my asthma is not good, where you've got an amber face with a straight mouth shape. I'm breathless, I'm coughing, especially at night. I have difficulty sleeping because of my asthma, or I need extra puffs 3 times a week or more. So it's pointing out to them, if they need to take extra puffs, it's showing they've got poor control. Something's going on. But remember, when you're consulting with that child, if they've been able to identify anything that's triggered, such as we're in pollen season now. So has it been that perhaps they're not taking antihistamines? They may need a nasal steroid spray. Again, you've got good technique for taking nasal steroids as much as inhalers. Often the problem with why they tell you they don't work is they're not using them correctly. So it's opposite hand, opposite nostril. Don't hold the opposite nostril, the other nostril, and you point outwards towards the outer eye whenever you're dispensing the dose, and it goes into the sinus cavities. So you've got the indications there of why the asthma is not good and what they should do. Then I'm having an asthma attack, the red, grumpy face. It says my inhaler is not helping despite increased doses of my inhaler. I'm struggling to breathe, have excessive coughing, a tight chest, wheezy, unable to speak in full sentences. It tells them what to do. Call 999, sit upright, keep calm, easier said than done sometimes, loosen tight clothing and take one puff, wait 1 to 3 minutes. If no improvement, take another puff of their combined inhaler. And then it says they should be seen immediately after an attack. If it doesn't help, call 999 again. So that's quite a nice sort of teenage friendly plan. And again, if you have got children who are moving over to MART, it's probably the most appropriate that I've been able to find for them as well. Obviously, we've got the Asthma and Lung UK paediatric plan that I think everybody's probably well used to using now. If we move on, please. I think the last slide is just, yep, it's just resources. So I've just got a list of different resources which may find useful. So it's got the guidelines now in asthma diagnosis and monitoring. You've got the Asthma and Lung UK children's pages on the Healthcare Professional Hub, which is very useful for healthcare professionals dealing with children. You've got Asthma and Lung UK, which is have a fantastic area for providing information to parent, child, guardian, whoever. You've got the Paediatric Asthma Control Test, which I showed. You've got the Paediatric Asthma Action Plan, and then also the link through to the Primary Care MART Asthma Action Plan as well. I think that was all I was going to cover, unless there's any questions, Christiana.
Thank you, Paula. Thank you very much. Yeah. So I'm just going to move to look at the chat to see if there's any questions. Okay, I can't see any questions so far. So
Okay.
does anyone have any questions they would like to ask Paula? I can't see the chat. So if they want to raise their hands up, or if they have anything in particular they would like to ask about the PQS. Okay, so I've got Hugh. Okay. I'll have to navigate this.
Yeah.
Yeah.
All right. So, thank you so much. That was so helpful. I just wanted to double check with regards to the asthma management plan. So you went through one from Right Care, and then I think Asthma UK does one as well. Which one would you tend to recommend to use for pediatrics? Because I tend to use the Asthma UK one for adults, but what would you recommend for pediatrics?
Yeah, I think certainly for the one that I showed is really just for children who are moving, well, for anybody really moving on to maintenance and reliever therapy. So I would say that, you know, the Asthma and Lung UK paediatric plan is probably the one I would choose to use if they're able to understand it. Sometimes I'll just put a picture plan together myself, where I'll just do a picture of the inhaler. I'll download it off the internet and I'll just put the number of doses beside it, that kind of thing, to simplify it. But I would say the important thing is go through the plan with the child so that they're listening to you, because they're not always with a parent or guardian who might actually understand it better. I also will send, you know, if the parent is with me, if you want to send it through by email link, that's fine. But I'll make sure possibly to print out copies so they can take one in for the school, grandparents, teachers, whatever. So you want anybody involved in that child's care to have access to the asthma action plan.
Thank you. Thank you.
Over to you, Dashna.
Hi, can you hear me?
Yes, we can. Yes.
Okay, great. Yeah, thank you for the presentation and all the information, Paula. It's really, really helpful in applying some of the kind of common practices. One of the common things is in this age group, though, is that they'll obviously have a SABA at home, but they'll have one in school settings. So two often get released always at the start. So it will always go above the threshold. All of them will kind of pop up because of the fact they're at school and they'll have one at school or somewhere else.
I think you just need to identify if there's any risk there as the main thing. I mean, that's the priority behind this. So if you're, you know, obviously, yes, schools generally want to have one issued at the start of a school year, so you can kind of discount that as not, as long as the child isn't regularly using it. But I think it would warrant just a discussion with the parents or guardian if they're then actually ordering more than 3 or 4 in a year. So maybe you can discount the one and then take it down to below that. But you do need to have that discussion. because you don't want to have that risk factor unidentified, really.
Yeah, no, thank you.
Okay, over to you, Emily, now.
Hi, can you hear me okay?
Yeah,
yes,
we can.
Lovely. Thank you, Paula. I just wondered if you had any general advice on the sort of asthma control test questionnaire, because it mentions about how many times have you used your reliever inhaler, and I wonder if that's confusing for them to know, you know, that you're using your MART inhaler as a reliever, and whether how they answer that.
I'm not sure quite. So, I mean,
Sorry,
oh,
I should say, so if
go ahead.
the current asthma control test questionnaire says how many times have you needed to use your reliever inhaler?
Yes.
And then I think it actually says in brackets your blue inhaler normally.
Yeah.
But obviously if they're using the same inhaler, I wonder if that's going to affect how people answer it, because they may say, well, I've used it twice a day because it's the same inhaler.
Yeah. Yeah.
And then it's going to affect their scores. You see what I mean?
So, I mean, good practice is that you do the asthma control test with the child at that point. So I know that doesn't always happen, but it is best practice. So, you know, that's where you would get less confusion. And as I say, children should not be reviewed by phone, and children should be seen. And in actual fact, I had some children I used to see. I had one in particular, I remember, she was really used to get quite poorly. I used to see her every other month, just routinely, to keep a sort of finger on the pulse, so to speak, to see how she was. But I think really with children, you have to see them face to face and to really get a bearing, and then you can do the test with them, so there's less confusion.
Thank
you. I wouldn't send it out, you know, in the way that being an asthmatic, I know mine is sent out to me, and then I never hear anything more, if I'm brutally honest.
Yeah. Thank you.
Okay, you're welcome.
Gillian?
Hi, so I just wanted to comment on the 2 or more inhalers question, and the schools and the grandparents and the parents and the nannies and the, you know, the kennels and the dog. And, you know, we know that patients do request inhalers for various different locations. We have no objection, like Paula said, for you issuing one initially, but they're not going to use all those inhalers and use them all up at the same time. So, you know, the PQS target this year, we're asking you to identify patients that are over ordering, but we're actually asking you to review the ones that are overusing. But, you know, so if you contact them and they say, yeah, well, we've ordered a load, but it's because of this, 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 and this, then that's fine. But we would hope that you would then go, well, okay, so you do need one at grandparents, but please don't order that replacement until that one's run out or gone out of date. And then don't issue 2 every month on repeat. So on your evidence review, you'll say they're not over ordering, they're not overusing, they're over ordering. We've had a conversation, we've reduced it from 2 on repeat to 1 on repeat, because whichever one's going out of date, they can replace that one, because all 6 are not going to go out of date at the same time in every location, or be used at the same, you know, because if they've got an inhaler, it's an inhaler at school, it's for that occasional use. They're not the ones that they're using every single day, so it's unlikely it's going to go out of date in a very short period of time. So for the PQS, we're asking you to review the overusers and identify the over orderers, but do something with both to try and reduce their need. And also, in line with the new guidelines, think about, have they got an ICS, and should we be encouraging them to use that more frequently and stop using the SABA as their main inhaler device. So just wanted to just give you some reassurance about what the PQS target is actually asking you to do. It's not review every single patient on the list, because we appreciate that lots of those will just be over ordering. We want you to review the ones that need a clinical review because they're overusing their salbutamols. Thank you.
Thank you, Gillian. So over to Taliha.
Hi, Paula.
Hi.
The question is about the use of MART in the age group of 5 to 8 or 5 to 12. That sort of age group where it's not licensed, according to the latest guidelines, are we still going to be encouraged to use an unlicensed product for them if it is clinically indicated?
Well, so I haven't been involved with the paediatric guidelines that are being worked on across Bob, so I can't comment on that. But I would say on our adult guide that we already have in Buckinghamshire and Oxfordshire, we actually use products that are off license for air therapy. So we do go off license, as everybody knows. And I think, NICE do say in the guidelines, they actually have put the comment in, they recognise nothing is currently licensed for using MART between the ages of 5 and 12. So they've got that recognition there. So it's just, we obviously, if anything's not licensed, we have to then highlight that during the consultation. But I would always reassure, the parent or guardian, it's just that they haven't gone through the whole research data behind it. But for example, if Symbicort's on, it's licensed from the age of 6, so it's safe to use. And it's what we would ideally get them to go on to once they're 12, that they'd be going to a MART, because we know it works better. It's easier for everybody to manage. So it makes sense that if they're not controlled on low dose ICS, to actually move over to that way of thinking. But you have to take everybody's situation into account, and it's not going to be working for everybody.
Okay, thank you.
Okay.
Okay, just checking. I don't think there is any more hands raised. Does anyone else? Oh yeah, there is. Oh, Vanita.
Hi. Thank you very much. Those were really, really very good presentations. This might not be the right forum for me to ask this question. So I work locally. Now, as you said, Paula, each consultation is going to take at least an hour, right? Now,
so sorry, what for spirometry it would, not for a pediatric consultation, a regular review, I wouldn't say it would be an hour.
So how long do you think that should take? Because I know for asthma COPD, it normally takes us quite a long time to review, at least half an hour, especially if you're going to go through the whole process.
Yeah.
Right.
So when I worked in primary care, which I did, say, for, dare I confess, over 30 years, and I'm a pediatric as well as adult nurse. So with children and with adults for asthma reviews, I had 20 minutes. With COPD, longer, because obviously it can be a lot more complex with comorbidities and severity of disease. So COPD, I on average got 30 minutes. But it depends. Some people that attend for review, they're doing really well. You're checking their inhaler technique, is spot on. They're managing well. They're not using many reliever doses, and so you can make up a little bit of time. Some reviews are much more complex, so not everything goes to plan, does it? Let's be honest.
No.
And sometimes you can end up running quite late. And I would be lying if I said I never did. So certainly I did on many an occasion, because if somebody's got complex needs, then it's going to be more difficult. But, I think the other thing to remember is I was always taught that, if you've got somebody who's relaxed and receptive, they'll remember 3 important facts from a 15-20-minute consultation. So you're trying to think for everybody that's in front of you, what are the 3 most important things I want them to take away from today? And then everything else you've got to write down. If that person or adult is anxious, they'll remember much less. So it's kind of always thinking about the main priorities for any consultation, and sometimes you need to see them again. You can't do everything in one sitting. So somebody that's more complex, tackle a little bit and then bring them back again, which obviously it takes up more time in the long run, but actually it's better that you address everything that's needed and then keeps that person safer, less likely to have an asthma exacerbation going forward.
Sure. So basically my thing is that, that in primary care, we are all fighting for time for every consultation. We're always.
I do. I remember it many times myself.
Yes. And then when it's
many
a PQS
battles.
target, it's even, I think there's more pressure because you're only going to get paid for, if you miss one, if you miss the children on asthma, that's it. You don't get paid for anything. Right? Is my understanding correct, Gillian, or anybody else here?
That's not my niche, Christiana.
I don't know what you mean, Benita, by paid for anything. I don't understand what that question was.
Because if we've got like 5 PQS targets.
Oh, okay,
right?
okay.
So we need to meet all 5 PQS targets to be getting the payment for it. Yeah, I think Gillian is nodding no.
No. So
Vanita.
Let Gillian answer that.
Go on, Christiana.
Oh, okay. So like I said, there are 5 targets and each target is 20 points. So you don't have to complete all 5 targets. You could pick and choose which targets you wish to complete. But the amount you get paid will be in proportion to the targets you've completed. So if you complete 3 targets, then you get 60 points. Then you get paid for the 60 points. And all the allocation and the values, it varies from practice to practice. And all that information is with the practice manager or your prescribing leads. We've sent that out for them to sort of review and then decide if they're going to do all 5 targets or if they choose to do 1, 2, 3, 4 targets. So it's all depending on what the practice wishes to do. But you have to also meet the PQS script switch requirements as well in order for the payments to be made.
Absolutely.
So that is one of the conditions. Gillian would.
Yeah, I think the only other thing to say is that obviously if you're doing a target and you're doing the asthma target and you've got 30 patients on that list, we would be expecting for all those patients to have been contacted to understand if they have, you know, just over ordering or if they're overusing, and for those that are overusing to have been invited in for a review, and the majority have had that review before the end of the 12 months, because you've got 12 months to bring those people in, and if they're overusing their asthma inhalers, then really they should be a priority recall. So, you know, what we wouldn't expect is to get to the end of April next year and to be getting evidence that comes back that says we're going to book them in with an appointment. Well, you've had all year to work on this. So, you know, if it comes back and it says we're planning to invite them in for a review at some time in the next couple of months, well, we probably won't accept that because you should have already actioned it. So what we are looking for is for those patients that are overusing and you know you're worried about them because their management is not good, that they have had an asthma review and there are some outcomes as a result of that review on your evidence that you return by the 3rd of May 2026. So, you know, but we do appreciate that you might contact some patients and they might not attend. That's fine. You need to document how you've tried to contact him. And again, we've got a box on our data collection which does say consider safeguarding, because if you're trying to get these kids in and they're not being brought in, often it's not within their control to come in on their own for an asthma review. So, you know, we're not saying you've got to report them to safeguarding, but it should be a trigger that you just crosses your mind that if they're not coming in for their asthma and they're not coming in for their, you know, vaccines and they're not coming in for something else, then that might trigger something to raise alarm within the practice. So, you know, we understand that not every child and not every patient that's on a list for PQS will be possible to review, but we do need clear indication of why that's not being possible. So I hope that's answered that question.
Yeah, thank you. So Paula, my question leading on from that was just a very quick one. Have you ever done any group consultations, or would it not work in this kind of scenario, especially with children?
Yeah, that's something that's becoming more discussed, I have to say. And actually just before COVID, I attended some webinars about how to run group consultations. So I haven't done them myself, but I know it's something that people are thinking about. Obviously, you've got your confidentiality issues, but you know, I would say for most children that they're going to be less bothered by that. It's something to think about. It might work. I think you'd be selective about who you invite with who, possibly. But yeah, it's not, if you do manage it, let me know how you get on. Be very interested to hear, actually.
Okay, perfect. Thank you.
I did it for Stop Smoking, if that helps. Back in the day when I used to do Stop Smoking clinics.
Exactly.
Because peer pressure, it really helped, actually. It was good for peer support. Well, peer support, I should say, not peer pressure, but peer pressure too.
Thank you, Paula.
You're welcome.
Well, we've got 2 minutes to catch up. I'll say thank you very much to everybody, and most especially thank you, Paula, for taking the time to present for us today. I'm sure everyone found it very helpful and useful. And any questions, any further questions, please ping us a message via the Bob MOT inbox. But thank you all, and hope you have a lovely rest of the day. Bye-bye.
Bye.